Hi everyone. Not sure it's going to work. Okay, good morning everyone. Good afternoon, I should say. First, thank you for being here. It's a real pleasure to have you in Vichy. We were supposed to have a half an hour introduction, but unfortunately Daniel Weguber, the president of ECOG, cannot be here with us today. In USA, actually presenting very important data to the American Congress of Obesity, so we cannot make it. But he tried to send us a welcome video. It didn't work. So everything is fine so far. So basically, I'm not going to speak for half an hour. So I only have 10 minutes of few informations to give you, and then after we will have just another 10 minutes. The first 10-minute break is just because we have also about 100 people online, and I really want to start on time so that they won't miss anything from the first session. So I will start now. So thank you very much for being here. I'm David. We have exchanged a couple of emails, so now we have faces in front of names. I'm very happy to have you here in Vichy. So why Vichy? Everyone has been asking this question since yesterday. So because you didn't know Vichy, and I'm pretty sure that almost none of you ever came to Vichy. So that was a good occasion to come to Vichy. And it's also a very important city for our country history. So you've heard about Vichy since the Second World War, but also about the Roman bath. And you might have a chance today to have a walk around and to visit Vichy and the buildings and the thermal baths. And I would encourage you to do it today because the sun is there. And I'm not sure it's going to be here tomorrow. So if I were you, I would take a few minutes to walk around. Vichy is a pretty walkable city. So I think it's pretty easy to walk. Everything is close by. That's the first reason. I would say the main reason, but we have also to be honest, and the main reason is also that my university is supporting this meeting. And my university is in Clermont-Ferrand, which is about 45 minutes from here. And they also have a campus in Vichy. We are in part of this campus, and they really want to develop their activity in Vichy. And I think it's very important also to participate to the strategy of our university, who is, by the way, supporting the meeting. So that was also a good option to have the biggest support from my university. But I'm very glad that you all made it here. And after last year's meeting that has been cancelled face-to-face and what finally online, we are pretty lucky to have you here. And I think I have a couple of informations to give you before we can start the scientific program. I think it's a nice scientific program, and I really want to thank all the scientific committee of ECOG and the local scientific committee as well for their work. It's been very important. So why Vichy done? So Daniel Weguber sends you all his warmest regards, obviously to all the board members, but also to all the attendees. And he's really looking forward to seeing you all next year in Bulgaria, as you'll see, but also during this coming year, because I guess that we're going to have some webinars as well. So I hope that you'll get the chance to participate to those webinars. So the main conference is going to be in this room, room A. And as you might have seen, there is also room B. For that, you might have two options. Favorite options is to take the stairs. It's second floor, easy stairs. And you also have an elevator just in front of you, and all the coffee break, all the lunch boxes will be in salle B. There is a nice terrace as well. And today the weather is nice again. And the posters are there. We don't have poster 2 this year because we have quite a lot of oral presentations and a lot of posters. And we don't have a specific tour, but I guess that it's part of our responsibility as academia, as the MDs, or just attendees to go and visit the posters and to ask questions to all those people who have prepared their poster for this meeting. So I think it would be nice if everyone could raise some questions to those people who have been working on that. So it's going to be Salle B. You might have seen that the cell phone is not working very well here. The service in this room is not working very well. But you have free access to Wi-Fi. It's called UniVic, and you don't need any password. So UniVic for University Vichy, and you don't need any password. That was first important information. The second important information is that on the program, it's been written that tonight's cocktail, welcome cocktail, is going to be in the City Hall. It will not. Actually, it will be here, second floor, because the weather is nice and we have the terrace. And tomorrow we're gonna have the plenary session with a conference from Professor Duberne from Paris. And she's gonna give the conference in the main city hall, actually. And we're gonna have a cocktail, because this year we made the choice not to have a specific reception with specific fees. We decided that everyone is welcome to the cocktail, and then we have a plenary and a cocktail in the city hall, which is very, very close by, but Google will help you. It would not be possible to do this meeting without two things: an amazing team, and I guess that you've met all my colleagues and friends, and this colleague has been organized thanks to them, and also sponsors. And of course, you've seen the sponsors almost everywhere. You have a permanent screen here with all sponsors. And I think it's important to mention that this year we had our university, Clermont-Auvergne University, but the main sponsors are, and the main one is Aprifel Foundation. And we really, really want to thank them. For those who have attended the webinar in May, it was also organized with the French-speaking Society of Nutrition and Aprifel. And it was a success. So we really want to say thank you to Aprifel once more for their support today and tomorrow, of course, with the new mandate of ECOG. And we also have the National Health Insurance, which is one of the main sponsors of the Congress. And it's very important because, as you've seen on the program, it's a very multidisciplinary program. So there are pros and cons with such a program. The cons is the fact that when you're an expert in a very specific topic, you might find only one or two sessions that are very of interest. But I think that then you will find your interest in those sessions and you will open your knowledge, culture, and maybe your way to treat obesity in kids, to prevent obesity in kids, to address obesity in kids. And I think that even though we are specific and we are working specifically on some topics, it's always great to hear experts in other topics, because I guess you all agree that the prevention and treatment of pediatric obesity has to be multidisciplinary, or it might not work, it will not work. So I think it's important as well. And this is also one of the identity of ECOG, to propose multidisciplinary approach and to translate research into daily practice. And I think this is something we really want to remind and to remember. I think I've said it all. So thanks again for your presence in Vichy. We have amazing speakers and I'm very glad they are here. Every session has amazing speakers, and I really want to say thank you to all those people who came from all over the world. We have 24 different countries, 100 people online, about 120 people on site. So it's quite a success, and without the ECOG board and the ECOG members, it would not be possible. So I really want to thank you for that. And I will just ask you to wait for 13 minutes to start the first session. And I'll call in 13 minutes the Professor Emma Boylan from Liverpool University to share the first session. And I guess that's all. So if you need anything, you have the front desk. Please do not hesitate, and we'll do our best. And thanks once more for being here. Again, so I guess now it's time to start the first session. Just two informations. The first one, I would ask all the speakers to to upload their presentation on the front desk in advance, and also to speak pretty close to the micro, so that online people can have a better sound. That's quite important. This is the online micro. We need to do our best to make everyone understand and hear us. And the second thing is that tomorrow, as I said, the reception is going to be in the main city hall. Don't you worry, it's not that far. It's walkable, and we will put maps tomorrow on the walls to indicate exactly where the city hall is. So that's going to be clear for everyone. So I guess now it's time to start this meeting with the first session. And to chair this session, I'm very happy to introduce Professor Emma Boylan from Liverpool University. So Emma has been a member of ECOG for years now, and she's also a member of the board. And I'm very happy, that you made it to Vichy. We've seen each other all over the world for the last couple of years, and now you're here, so it's great. Very, very nice to see you all here. Thank you, Emma, and I will leave you start the session right now. You can use this one.
Thank you. Welcome everybody. It's great to be here in person. I don't know about you, but I was very bored of the online meeting, so it's much better to get to see people in 3D and to have all the networking that goes along with these meetings, as well as the wonderful presentations. But without further ado, we will move on with this first session, looking at pediatric obesity management across Europe. I'm delighted to welcome Dr. Brendan Vikram-Sige from the World Health Organization Regional Office for Europe on the prevention and control of NCDs. He's going to give us an update on what the WHO are doing around pediatric obesity at the moment. So welcome to Brendan. Thank you.
Thank you, Emma. Thank you, David. Thank you, Emma. Thank you to the board for inviting WHO for this meeting. I hope you can hear me. Yes. Yeah, these are my slides. Let me see. Right. So I will give you a brief update on what WHO is doing related to this topic, and feel free to ask any question at the end of any information you need. Thank you. So as WHO, we are working on many issues related to non-communicable diseases. So my office works on non-communicable diseases for the 53 countries in the WHO European region. So that's all EU countries, Central Asia, Eastern Europe, Balkans, Turkey. Those are 53 countries. We work on NCDs and all the NCD risk factors, nutrition, obesity, tobacco, alcohol, physical inactivity, all those topics. And it's important to look at what causes, what contributes to the disease burden. And as you can imagine, obesity or high BMI, unhealthy diets, they are at high on our list of causes contributing to the disease burden in our region. And obesity, as of this year, will be the highest contributor to disability in the WHO European region. So while we have an aging population, we are talking about improving quality of life. It's really important to address obesity right from the beginning. And we talk about the life course approach for that. So pregnant mothers, nutrition, children, obesity at early ages, and then adolescents and adulthood. Now, that's why when we understand that focusing on obesity is important, we have published several reports to work on that. WHO has 9 global voluntary targets to address non-communicable diseases. They include reducing tobacco, alcohol, improving physical activity, salt, etc. All these targets except obesity, are coming down. I mean, we are aiming towards the target, although we might not meet the target. But for obesity, we are going up, right? Still obesity levels are going up. So that's the only target which is going in the opposite direction. So still, we have not been able to tackle this issue or get a handle on the issue while we were aiming to halt the rise of obesity by 2025. Now, as of 2022, still obesity levels are going up. This is across the population, not just children. So that clearly shows why we need a better approach, better coordination, more joint up approach to tackle the issue. And to that, we've launched this year WHO Regional Obesity Report. Aim was to bring all the statistics related to obesity into one place and to look at what countries are doing, look at the best examples, and to provide a comprehensive knowledge about what we should do if we want to tackle obesity in the European region. And we hope that this report will drive us until 2030, until the Sustainable Development Goal targets where we want to go. So we hope next 10 years or 8 years that we will work with this report for those recommendations that we want to implement. And in this report, one of the first things we did was bring all the statistics into one place, because earlier we realized some countries are really interested about obesity under the 5. Some countries on primary school children's obesity, some on adults. It's very few countries who look at the issue at the life course, all of those data sources. So first we have projected or shown you the trends since 1970s or 80s. And I think anyone looking at these graphs, here up you see overweight, including obesity, below for obesity, sees why there is a problem in our region, why we need to take action, right? If the graph is still going up and the rate of increase in recent last 10 years, you can see. And then we tried to present data for the essential part is cut up there, that is children under the age of 5, okay? This graph is for children under the age of 5. We wanted to present data at different stages in life. And for European region, we realized that we are the weakest region when it comes to putting data, national level statistics for children under 5, their overweight and obesity rates. It may be some issue that we feel that we are developed and we don't need to focus on maternal and child health anymore, whereas other regions have very good national level statistics for every child or national representative samples about their measurements of under 5. We are from countries where is your national level statistics related to that, it's very patchy, coming from few medical centers, coming from one region, not national level data. So we are trying to address this issue. How can we gather good data to inform policies from children under 5? I'm sure it exists in all the hospitals, in all the clinics, somewhere, but it's not in a way that the policymakers can use to get a picture about the country, different regions, different socioeconomic groups. So this is one of the areas that we are really going to focus on those, how to improve our statistics and understanding about the problem under 5. We had the expert meeting in Slovenia last month, actually 3rd of October, and we are continuing this discussion with the European Commission colleagues as part of a European Commission project, but also with several other WHO member states, how to improve this. So this is one of our aims for the next few years, to improve the quality of data for children under 5. And for primary school children, we have the best data, WHO European region. We have the Childhood Obesity Surveillance Initiative in 44 countries, the largest childhood obesity surveillance initiative in the world, with more than 1 million children measured. And that survey shows 1 in 3 primary school children, these are children aged 6 to 9, they live with overweight and obesity. That's a big number. And that shows how much workload that the health system has to do to cover 1/3 of primary school children. And my next slide is about country specific. This is overall statistics for the European region for the 53 countries. Not sure which way I should aim, I'll try. Actually, can you change the next one? Yes, that's right. Thank you. So these are all the countries which have data from the childhood obesity round 4 data, COSI data. You can see in some countries up here, like 40% of the boys, primary school children boys, are living with overweight and obesity. That's 40%, right? And in countries in Central Asia and Eastern Europe, it may be 15% to 20%. So it's a wide range when you have 40% of the boys or girls in primary schools are living with overweight and obesity. And that shows that why we need to look at this in a more comprehensive way. Now, these are comparable data from our child obesity surveillance initiative. Some of the colleagues who are involved in this initiative are in the room, and this can inform the problem, but also countries can use this data to monitor the impact of policies that they are taking. As I mentioned, countries are taking action, but we are not seeing the reduction that we would like to see. In few countries, such as Portugal, we see leveling off or slight reduction of obesity among primary school children. That's because they have had several policies aimed at this age group and tackling it, but very few countries, 1 or 2 countries still. But overall reduction, we are not seeing. This is children, adolescents among 11 years. Again, similar picture. This comes from health behaviors of school children, HBSC. But in this one, we ask from the child their height and weight. In COSI, primary school children, we measure them. So that's the difference here. It's self-reported. Some countries keep a scale in the room so children can get on the scale and check their weight before coming to the examiner and tell them what their weight is. But still, this is a bit of a self-reported. So you need to take into context when you compare that data, HBSC data and COSI data. Some people ask why COSI has higher level of obesity for primary school children and why it is gone down when it comes to 11 to 13 years. We think partly the answer is the adolescent survey is self-reported. It's really difficult to get ethical clearance for countries to measure children, teenagers, and touch them, and all the measurements has to do. And that's why principal investigators don't like to go for measurements for the HBSC survey. They like to keep it self-reported to increase participation. There's a good response because it's not measured, but COSI is measured data. And now we are trying to understand what happened during COVID, what happened to the obesity risk factors and all the obesity. So 26 countries are working together on a comparable scale, a slightly adapted questionnaire and a tool to collect data. I think about 14 countries have already collected data, and we are now getting data cleaning. Hopefully early next year, we can present how did the COVID impact on childhood obesity risk factors and what happened during that period. Another piece that we did for the obesity report is really making the case between obesity and cancer. What we realize is, although obesity is a topic that speaks, the health practitioners or even the policymakers are not taking decisive actions. But when at the EU, we have a very big initiative on cancer. Every issue that has been linked to cancer has got political attention and action. Best example is alcohol. We never thought that your president in France will come forward supporting warning label on wines, right? He came forward with that when we showed the evidence that every alcohol buying gas causes cancer and contributing to breast cancer, that all EU thought France will never agree on a warning label on alcohol. But it did, right? When we show the case. And that's not because of the evidence was always there about alcohol and cancer. What changed was really putting it out now in a simple way when there's a huge attention at the European level, EU level for cancer reduction, showing what are the best interventions if you want to reduce cancer. So that's what we try to do, working with the International Agency Research on Cancer, with IARC, to simplify, summarize the evidence from obesity to cancer, show which cancers are directly linked to obesities with good evidence, 13 cancers, and also other evidence. For the first time, we were able to say intentional weight loss reduce the risk of cancer. This was very important. And that has never been done, stated clearly by WHO and IARC. In this report, we say that if you lose weight, it reduces the risk of cancer as well. And we hope those things will contribute to get the attention and health system investment we need to tackle obesity from early ages. We look at different policies countries are implementing. I will share this slide. You will get them. How many of them have, what the percentage of countries have physical activity or other action plans, and what are the most commonly implemented intervention. Most countries commonly implemented policies, public awareness campaigns. And we know public awareness campaigns alone will not give us the health outcomes that we need. And we also ask about different existing policies for obesity. And only most of the countries say they have a program to measure height and weights, but less than half of the countries have national guidelines, protocols, or standards for management of overweight and obesity in primary healthcare. So this is the area that where we need to really work on, including pediatric obesity management, development of guidelines, and conducting audits, training primary healthcare professionals, not just the pediatricians, but primary healthcare workers for having proper referral systems and building that capacity. Capacity in the clinical setting for the healthcare workers, but also the capacity of the system to train them, to provide those resources, to invest in that, and also to manage the referrals. And it's difficult. As you can see, you can't achieve it just by training doctors if the system is not ready for that. So we are working on several manuals, how to bring that capacity for healthcare managers at regional level and national level. And we look at policy recommendation across for all ages, obesity management on that hand. We ask from countries, what are the policies you are struggling to implement? Where do you want support from WHO? So they say they are struggling to implement equitable access to integrated healthcare services for management of overweight and obesity as part of universal health coverage. This is because they feel our national focal points that people who can only afford, who can pay for it, are getting these services now. National health systems are not paying for multi-sectoral, multidisciplinary weight management programs as it should be. And there is a huge inequality on children and families who have access to this program. So this is an area, despite training doctors, if that benefit is only going to the families and children who can afford it, we are widening the inequalities. So countries are saying under the universal health coverage, we are struggling to invest in that. So we need good lobbying from clinicians, doctors, everyone, for the country's health systems to invest in it, not just for those who can afford to pay. Equitable access to family-based multi-component lifestyle weight management services for children and young people who are living with obesity. This one is based on a series of interviews we did. Again, the conclusion is, it looks like when we want these multi-component weight management programs, the parents or the families have to do a lot of coordination and finding services. So those who have time to do that, those who have money to do that, and at certain education level to do that, able to navigate these services. But others are not able to navigate the services. So how can we really give that benefit and organize the services in such a way? So WHO is working on a health system response to obesity management. Some of the experts are in the room who's contributing to address that. So those are two issues, but all the others, diet, physical activity, and data collection, now policy recommendations are here. Then we asked, okay, none of these are new. In 2010, we knew all these policy recommendations, but last 10 years, our implementation has not gone up. Obesity levels are still going up. Why didn't we implement what we knew 10 years ago? We asked from each country, national focal point for obesity, what are the barriers for implementation? Our report has a long list, but this is all I could fit into one slide. But one of the issues is that lack of guidance on how to implement effective integrated obesity treatment and management comes up. No consistent guidelines and protocols. Like for hypertension management, we have very clear guidelines and manuals, and they know how to roll it out and scale up. For obesity, that is not the case. Maybe it's more complicated than hypertension, but still we need to have clear guidance. And there is all the other issues. We know obesity management also requires prevention part, the obesogenic environment, and that has other stakeholders, not just health. And there are commercial determinants involved, income for companies, food companies, marketing, and those sectors are sometimes hindering some of the comprehensive obesity policies countries are bringing forward. And this is a challenge. There's always vested interest and interference from commercial interest for obesity policies. And then even the obesity management part get compromised or get affected from that. Now, other aspect in this report we have highlighted is the need to listen to children or adults and families, people living with overweight and obesity, not just designing programs by health experts and researchers. So we interviewed a series of families and children and adults who are living with obesity across the region. This is only 2 quotes, but the report has caveats from lived experience of obesity. And it talks about various things like Some mothers say, I took my child to the clinic and there was not a single chair that my child could sit in the clinic, right, for a child living with obesity. And that itself, that mother says, as a health system not recognizing the problems faced by the families and children. They're simple things. And we presented this, one of the head of the ministries in EU countries said, I never thought about this issue. This is something I can easily fix next year, but I never thought about it. No one brought it to my attention. So my key message is, have a system to listen to the families and children and how to take it to our policies. So we have a long list and we are continuing this piece of work to really provide feedback for the policies. Current obesity-related activities in the WHO European region. So we have a signature initiative from our RD, NCD Advisory Council. How can we really escalate the attention? And how can we get the attention from policymakers, not just at the ministries of health, at the highest level of the government for obesity, including childhood obesity. And we have a signature initiative on childhood obesity led by the First Lady of Croatia, who was a principal investigator for childhood obesity. And she's an epidemiologist, professor in epidemiology, and she's the First Lady. Her husband was the health minister before. So Croatia came to WHO and said, we need more advocacy for obesity, and she's going to organize a summit, which I'll tell you later, and how we can get the attention at the head of state level to tackle obesity. Surveillance, as I mentioned, measuring across the life course, children, adults, initiating obesity policy dialogues, and also obesity management in primary healthcare courses. Now, these are sub-regional policy dialogues we organized this year. Following the launch of the report, we are using the report to organize, bringing countries together to talk about what we can do. First one was in North Macedonia for Western Balkan countries, led by the First Lady of North Macedonia. She's a doctor again, and the health minister of North Macedonia for all the Western Balkan countries. How can we take this data and the report and implement them at country level? And they will lead a program to train public health, primary healthcare workers for the management of obesity in the Western Balkan region. Second one, I think you're saying, is from Kyrgyzstan for Central Asian countries, where we met with all the ministries and national stakeholders from Central Asian countries, again, to bring obesity and find finances to invest in that. We have launched several courses for WHO counterparts through the Ministries of Health on obesity management and through our WHO Europe NCD office learning platform. And we have an e-learning platform with all the courses. Some of the experts are here. This is the childhood obesity management capacity building course. It talks about definition of overweight and obesity, trends, health consequences, clinical evaluation, management of obesity, quality of care for patient safety, how to address weight bias and stigma, barriers to childhood obesity management, and other policy recommendations. We are also developing series of tools which helps healthcare providers to initiate the dialogue. How can they talk about the issues and provide brief advice for children and families? So we are working on this training course at the moment. And as you know, breastfeeding is breastfeeding training is quite linked to addressing childhood obesity. WHO European region provide the best evidence about the benefits of breastfeeding. That's the highest investment onto research. We are the lowest region in exclusive breastfeeding in the world. And when I sit with my other colleagues from all the other regions as the regional advisor for nutrition and obesity in the European region, I have the worst statistics for exclusive breastfeeding, despite telling the whole world how beneficial breastfeeding is for health. So this is, we see the evidence. We have context relevant evidence, but we can't implement it. There are so many other factors. Okay. The other countries, the problem is evidence is coming from Western Europe and they say, oh, our evidence is not context relevant. We don't have that problem. But so it clearly shows what are the other barriers here. And there are a series of barriers. I don't want to go into detail, but that include partly in our region, the threshold for prescribing recommendations by doctors and pediatricians to introduce formula milk for mothers is very low, very mild rashes, one-time rash. Pediatrician encouraging mothers to take up formula milk has been seen as a major barrier for exclusive breastfeeding rates. And this is not based on evidence. This is based on practices and workshops mainly sponsored by the industry. So we have to be very careful about where is the evidence, how can we develop evidence-based guideline and training and work with healthcare professionals to have evidence-based practice in the heart. And at the moment, Europe is not there, unfortunately, despite having best evidence. So we are working now to put a course on a baby-friendly hospital initiative for breastfeeding. And we did the course a few months ago with 140 participants from 14 countries. And we are putting the course again for member states again in next few months for some Western European countries. As I mentioned, the child obesity management also need to be linked with having a good policies in the country for prevention. So we are working on series of issues. Digital media is one of them. Digital marketing of unhealthy foods. I'm sure we have a session on Friday on that. We'll talk about it. And inappropriate marketing of breast milk substitute and baby foods. The code is violated repeatedly in the European countries. The follow-on milk is used as a way to promote to mothers, and also unhealthy baby foods is marketed in the region. This is that paper. And also we recently look at the political activity of industry to tackle sugary drink taxes in our region, how industry is interfering with government policies. It was published recently, and other issues such as healthy and sustainable diet. So this is a series of policies that technical material we are developing to support the obesity program for member states to take it forward. Finally, I want to talk about this brief project, which we are launching next week, 2 weeks, 15 and 16. This is brief intervention in primary healthcare about diet, physical activity, tobacco, and alcohol in an integrated fashion for children and adults. We think it's very important that primary healthcare physicians feel confident to ask about it. Our survey shows many doctors don't do that unless the patient asks for it. When the mother and child come for a vaccination, they don't ask about the diet or physical activity. They think patient will not value that time. Patient says, when we ask how many times did you visit your GP last 5 years, how many times did they initiate a discussion about diet or physical activity? 90% of the time patient says no, right? So we have these 4 risk factors, which contributes to 80% of the disease burden. And 90% of the patients don't, when they come in contact with the healthcare system, we don't take the opportunity to talk about them or initiate a dialogue. So there's a clear mismatch between the health burden, needs, and what we really deliver. And when we ask from the doctors say, no, we know this is important, but we think patient will feel this is a waste of time. They came for something else. So there are several barriers at system level, attitudes, practices from patients, from doctors. We are trying to look at this issue and take it up a dialogue with health ministries and practitioners. So this project we are launching in 2 weeks. For the first time in 20 years, I think WHO bringing this brief advice for all 4 risk factors together to have a common approach. My final slide about the signature initiative. This is the First Lady of Croatia, Professor Stanja Milanovic, our regional director, Dr. Hans Klug, in Israel last month during our regional committee, where we announced that we will be establishing a network of First Ladies and Gentlemen in the European region. Network of First Ladies and Gentlemen to tackle childhood obesity. And their first summit will be in Zagreb on 26th of April 2023, which we really want to get the attention and scale up our work on childhood obesity. Thank you. That's all. That's a brief update about the work we are doing.
That's brief as it can get when you're doing that kind of work. Impressive body of work. Thank you very much for telling us about it. Do we have any questions from the floor? Please say your name and affiliation as well.
Thank you very much. I'm Klaus from INRA in France, the National Institute for Agricultural Research and Environmental Research. So you mentioned at the beginning of your talk that the trends in the Europe region were really bad as far as this is concerned. So how different is it in other regions? And how do you see the specific obstacles to obesity prevention?
Thank you. So in general, overall obesity rates are going up globally. So in that case, but the children's obesity levels are higher in Europe compared to other regions. So in one way we can say it's bad, but on the other hand, we can say, oh, that's because we don't have malnourishment and we solve a set of problems that we have a different kind of a problem. So it's very difficult to say one answer, we are better or worse, but I think that our childhood obesity surveillance data shows we have higher obesity levels for children than other countries. On the other hand, we are the only region who have data at such scale to recognize or measure the problem. So for the primary school children data, we have the best, but under 5, we don't have very good data. In terms of obstacles, our report exactly that question. That is the most important question. What are the barriers and obstacles? That's why in our obesity report, we have a whole chapter about that. We interviewed all the policymakers and asked, you knew the set of policies we have to implement. Why didn't we do it? One of the reasons is for obesity, we can't expect one policy to solve obesity. We need the broad range of set of policies to be implemented, and they require a lot of political commitment. What we see is countries are trying to implement 1 or 2 policies. For example, sugary tax in the UK, or Nutri-Score labeling in France, right? That is a good policy, but that alone will not solve the obesity problem. So every country is implementing 1 or 2 policies with good political support, but they are struggling to implement full set of policies in a comprehensive way at the same time with good political support. And we think in that way, the industry is also interfering with the government prioritization, saying, okay, this policy will cause loss of economic growth or loss of jobs, and they're also delaying some of the policies. So those are the main challenges we see. Thank you.
More questions? Thank you. I noticed you said before, in terms of the barriers to policy implementation, one of them was that economic sort of considerations take priority. Do you think the message about the economic costs of living with endometriosis is being lost?
Yeah, so in one sense, we are working with OECD. So we are launching a new report, hopefully in the next couple of months, the cost of physical inactivity in the EU or for all EU countries. So it's comparable methods for the first time. So far, in each country, methods were different, but we are working with OECD. So we are trying to bring the economic arguments of obesity, physical inactivity, unhealthy diets to support that. And it looks like most of the time, our consumers for that data is also the Ministry of Health. But when the governments are trying to implement a policy, taxation policy for unhealthy food, the industry goes to the Ministry of Economy and say, look, this policy will lead to either people going to the next country to buy food, cross-border trading, or loss of jobs in supermarkets or something like that. And then they listen to those companies more than their ministries of health, unfortunately. That's why, in one way, we want to empower our ministries of health with good data economic argument. On the other hand, we really want to get prime ministers and presidents on the issue to understand, to balance that in the cabinet or in the ministries. That's why that signature initiative, we think first ladies and gentlemen can do a better job convincing heads of state. So we hope children's obesity is a good cause that most of them personally care about. Not First Lady of Iceland is personally care about that. First Lady of Turkey, First Lady of Serbia, they have personally initiated programs in their countries. So having a group of First Ladies and gentlemen hopefully will help us to raise the importance of these policies at the heart of the governments. At the moment, unfortunately, health ministries have not been able to convince the ministries of economy about the impact and importance of those policies.
We have any more questions for
The US and tremendous disparities in child obesity with regards to ethnicity and economic factors. Did you have data in these to look at those kinds of disparities as well?
Yes, we have. Sorry, I didn't present the breakdown data. We published a supplementary volume on obesity reviews last year, actually, that has a separate paper on socioeconomic aspect of the childhood obesity surveillance initiative primary healthcare data. It's pretty similar to, we don't have one single summary statement when it comes to socioeconomic status. In some countries, we see primary school children obesity levels are higher in higher educated groups. Some countries, in low socioeconomic groups. So we don't have one single line that in the WHO European region, childhood obesity is higher among lower socioeconomic groups. It's pretty mixed, but the data is in the obesity review supplement we published from COSI data last year. Yeah, we have data. Thank you.
Thank you very much. And I know Kevin will be around for a little while. So
I will be. Thank you.
Great. Thank you very much. My pleasure now to introduce Professor from the Pediatric University in Munich, who's going to be talking to us about pediatric obesity and health COVID-19. Thank you.
Thank you very much, Emma. I also would like to thank David and the organizers for giving me the privilege to join this meeting, A, and B, for giving me extra time. When I came to this conference, I had a program that gave me 30 minutes. Now I see it's 45 minutes and it's actually 55 minutes. So I can probably speak slow, or we can have more time for discussion. And I can also use the extra time to share with you what you've seen already on the screen there, that ECOG has partnered with the journal Annals of Nutrition and Metabolism that I have the privilege to serve as the editor for. And I'm really happy about this partnership. We've published some wonderful position papers from ECOG with great information. And I would like to encourage you all to consider submitting your best research in childhood obesity to this journal, because it's sure that you have an editor who has an interest in the topic, and it's an impact factor of almost 6. So be aware that we have a critical review process. We only want good research papers, but it's an opportunity that I just wanted to remind you of. So the topic I was given today is COVID-19, pediatric health and pediatric obesity. And since I thought this is a bit of a mixed audience, not everybody is coming from a background that is close to medicine, I would give you a little bit of an introduction of COVID in children and then go on to health and obesity questions. I don't declare a conflict of interest. My work in this area is funded by the German and national public funding agencies. So this is what I would like to share with you: COVID in children, and then secondary effects of the pandemic and of the lockdown measures on physical activity, sedentary behavior, diet, and body weight. And then look also at a bit of a broader spectrum, what happened in medical diagnosis in children, looking at data from pediatric outpatients, effects on psychological and behavioral conditions, and finish with some learnings. So we're sitting here in a room together again after we did not do this for 2 years. And I see that none of you carries one of these. One is actually, okay, but almost nobody. So we might think that COVID is behind us, right? That's actually not quite the case. This is the recent data from my country, Germany, but I think it reflects very much what's happening all over Europe. In Germany, we have now almost 36 million recorded COVID cases. And of course, that's a big underestimate, because now many people don't test even anymore if they have an infection. In the last 7 days, it was almost 300,000 infected people reported. The 7-day incidence now is 350, and we have a total of 150,000 plus people who died with COVID, a big city of deaths. And if you look, this is perhaps the most interesting part of this. At the bottom right, the cumulative incidence, you see we have more COVID cases now than we ever had before. And in my city, in Munich, in fact, at the moment, we have more COVID inpatients in the hospital than we ever had during the whole year, pandemic time since the beginning of 2020. So it's not over, it's still with us. And if you look at children, in Germany, 16% of the reported cases are children. Again, this is an underestimate because children more often have mild disease courses, have asymptomatic diseases, and children always have infections with fever. So many of these children who have COVID are not tested. So I would guess the real proportion is greater, but you can see the number of cases reported in children is greater than the proportion of children as part of the population. So children have at least as much COVID as adults. But as I said, the infection in children is more often mild or even asymptomatic than in adults, and particularly in elderly people. So we might ask, can we disregard COVID in children? Is it not relevant? Well, we have a large number also of children that come to hospital. Overall, in Germany, we have 7,200 children that were reported in this voluntary register as hospital patients with COVID. Again, it's an underestimate because we don't have an obligatory registration. It's just pediatric departments volunteering to register. And again, you see that in 2020, since January, we had many more hospitalized COVID cases than ever before. The risk to have a severe COVID course is markedly increased in children who have pre-existing other disorders. It's about threefold higher in this meta-analysis in children who have pre-existing conditions. And also the risk to die with COVID is about threefold higher if you have a pre-existing disease. And the one disorder that sticks out, like in adults, is obesity. If the child is obese when getting COVID, the risk of a severe disease course is 3 times increased. So that's another consequence of obesity that I think should motivate us to really work harder on preventive measures. If you look at the children in Germany that come to hospital, 42% of them were infants in the first year. Half of the cases were in the first 2 years of life. And within the group of infants, half of the cases were children between newborn age and age 2 months. So it's particularly the young children, the young infants that are at risk of being hospitalized, of having a disease course that requires medical intervention. This is a meta-analysis of 65 publications with 1,200 children below 5 years of age that show you in these children with laboratory confirmed COVID-19, there's a lot of severe disease courses. Half of them, again, were in the first year of life. 3/4, of course, had fever. 1/3 lower respiratory tract infections. Interestingly enough, 3/4 have gastrointestinal symptoms, and we know now that is binding of the SARS-CoV-2 virus to mucosal epithelia, also in the gut. 70% got antibiotics, almost all got antivirals, 2/3 got steroids, half required oxygen. So it's really not a mild disease. A mean hospital stay was 5 days. And at hospital discharge, again in Germany, 21.6% go home with residual problems. So only 3/4 or so are out of hospital in a good shape. 22% have considerable remaining problems when going home. One severe consequence, of course, is the PIMS. You can't see it here in the room, but probably online because it's a little bit blocked here. It's the pediatric inflammatory multi-system syndrome with persistent fever and inflammation, single or multi-organ dysfunction that often requires intensive care treatment and has severe burden of morbidity and even mortality. This is not very frequent. We have in Germany 913 PIMS cases reported, again, voluntary register, compared to about 5 million infections, that's a low risk for the individual child that is infected. But for those that are manifesting with PIMS, it's a very severe disease, with 3% having residual damage, lasting damage, and not full recovery. Okay, that's the infection itself, but probably what is more worrisome to this group is the adverse effects of the measures that were taken against the pandemia, the lockdown, the school closures, and the like. So we looked at that in a study that we performed in the fall of 2020, already 2 years ago, where we basically asked 1,000 families with children up to 14 years of age, what has been your experience in the first 6 months of the pandemic? We found that in 2/3 of the families, at least one parent was working in home office, 1/2 each, always or partly. And that was, we'll see that in more detail, of course, happening more with higher education and higher income. 30% of the families cooked more often at home. And these were particularly parents in the home office with the higher socioeconomic status. There was surprisingly for me very little change in the use of takeout food or food delivery to home. There was a market decline. Is the microphone not working?
This one is for the
Oh, I'm sorry, I didn't know that. I thought this microphone was, sorry. Did you hear anything at all? All right, so as you would all expect, there was a market decrease in physical activity. Overall, 38% of the children said we have markedly less physical activity. Higher at school age, at 13 to 14 years, it's 57%, 6 to 9 years, 41%, 10 to 12, 50%, less so in the younger age groups. And of course, that's obvious. If the schools are closed, if the sport facilities are closed, if the children sit at home in front of screens, there's less physical activity, more sedentary activity. And that is not only the case in Germany. This is a study from the US, from families with children aged 5 to 8 years or 9 to 13 years, relatively small samples, but it's basically the same result. Many children report less physical activity or much less physical activity, like in our study, more so in the older than the younger children, and also much more or somewhat more sedentary behavior in the first pandemia wave, that is, and that is what we would all expect. Also, the diet changed. 14% of the families reported the diet has become healthier. Remember that parents in home office cooked more at home. These were the children, the families that had more fruits and vegetables, less meat eaten than in the school meals. But the less healthy diet was reported in 7%. So more food and vegetables, less meat with parents in the home office, but more sweet and salty junk food and soft drinks if parents were not in the home office. And that is age-related. It's a very little increase of junk food in the young age group, but here in 10 to 12-year-old and 13 to 14-year-old, it's 20 up to 30% more junk foods and soft drinks that were consumed. So I told you before, 2/3 of our families had 1 or 2 parents in home office, about equal proportions, fully or partly, and that was more frequent in families living in larger communities. So for example, in small towns, less than 5,000 people, it was 53%. In large city with more than 500,000 people, it's 3/4 of the parents. And you see it's very much related to education and household net income, with low, intermediate, high levels of education. Predominantly home office is 12, 27, and 39%, with lower, medium, and high incomes, the same gradient, 22, 28, 45%. That's understandable if you work at this as a supermarket cashier or work on a production line, you don't work in a home office. If you have a better job, a desk job, then you can work in home office. And that has a clear reflection on the change of the children's diet. Overall, 14% reported the diet is healthier. If people were in the home office, mostly it was 20%. If they were never in the home office, it's 8%. Again, fully understandable. If the parents are at home, cook at home, then the diet can be changed. Home cooked food in the pandemic, same pattern, 43% if parents were mostly in home office, 18% if they were never in home office. If you look at the increased consumption of soft drinks and junk food, you can see a clear age pattern here. Soft drinks increased markedly up to 20% here in the older children, same with the salty snacks and the sweet snacks. It's mostly the older children that have a marked increase of the foods and drinks that we would not recommend. Boys are more susceptible to this unhealthy food pattern than girls. Also not surprising, often found in many other studies independent of the pandemic, but the difference here in increase in soft drink consumption, carbohydrates, salty snacks, sweet snacks is quite impressive that there is such a big gender difference. This is another study from Pietro Bello in Verona, who looked not at healthy children as we did, but at children with obesity in northern Italy. And you see here quite amazing changes during the Corona lockdown. Potato chips consumption increased almost 9-fold, red meals doubled, sugar drinks 2.3-fold, screen time increased 2.8-fold, sports reduced to 36%. So if you look at this, less physical activity, more unhealthy diet, the result is predictable, what we would expect. And it happens both in the parents and in the children. In parents, an increase of body weight was reported in 27% during these first 6 months only of the pandemic, similar in males and females. In children, overall, it's only 9%, but again, it's very much age dependent. In 10 to 12-year-olds, it's more than 20% that showed a weight gain during, again, the first 6 months of pandemic only. This was also found in a meta-analysis, again, only during the first pandemic wave, looking at the effects of the lockdown for 1 to 5 months observation period compared to pre-pandemic data, 12 studies, 8 countries, developed and low-income countries or medium-income countries all around the world. And the result is basically the same. BMI changed on average by 0.8 kilogram per meter square. The risk of overweight or prevalence of overweight increased 1.2-fold, and obesity increased 1.23-fold in this meta-analysis. What is particularly worrisome in our data is that we have a marked increase of disparity. Michael had already alluded to disparity before. We all know obesity is very much related to socioeconomic status, but that has really aggravated in the pandemic. The risk of weight gain is 2.5-fold higher if you're coming from a less privileged family than from a privileged family during the pandemic. And again, it's understandable. With higher socioeconomic status, families probably had more opportunity to be physically active with their child. If you live in a poor quarter of the city, you have much less opportunity to do that. And we've seen also the effect on the diet being related to socioeconomic status. This was also found in the United States here, an analysis of 500,000 doctors' visit in outpatient clinics in Philadelphia. And you see here very much the same, an increasing disparity of obesity prevalence depending on family income. That's something that we cannot just watch, where we really have to be active with targeted measures to counteract this. So in summary, we see less physical activity as a consequence of the pandemic measures, particularly in older children, poor diet, particularly in older children, in boys, and in children of families with low socioeconomic status, an increasing weight gain, and an alarming increase in socioeconomic disparity. Again, in our data, 2.5-fold higher risk for weight gain in the less privileged children. Next part is an evaluation of the ICD codes of outpatients that are treated by doctors in Germany under the public health insurance, which is more than 90% of the population. We evaluated all children up to 10 years. In quarters, we have a system where the ICD codes are entered in the quarter of the year before and during the first pandemic wave, and we compared the same quarter, in this case, the second quarter of 2020 and 2019, so in the same period of the year, and more than 8 million children each. The first observation we had was that outpatient visits decreased by 18% in the pandemic as compared to before. So our first thought was, oh dear, this is a worsening of the medical care because parents don't dare to go to the doctors, but that's not the explanation. I'll show you the real explanation in a minute. But obviously, if there's 1/5 less doctors' contacts, there's also less opportunity to talk about healthy lifestyle, about obesity preventive measures. We had no change in the frequency of diagnosis of chronic disorders. You see it as examples of diabetes, celiac disease, and hay fever, absolutely no change. So our interpretation is if the child had a real health problem, the families went to the doctors, they were not scared to go if they had a real problem. What we saw was a marked decline of diagnosed infections by more than half. All infections very marked for gastroenteritis, otitis, streptococcal angina across all the ages, gastroenteritis and otitis mostly in the younger children. So yes, lockdown works. It prevents infections, not only COVID, but also other communicable diseases. And in fact, if we look at the marked decrease of infections, which of course are very frequent occasions in young children, along with the decrease in injuries, which we also noticed, that by itself explains almost all of the decrease in doctor's visits. So there were less doctor visits for good reasons, because children were less often sick. Interestingly, in the first wave of the pandemic, there was absolutely no change in psychological and behavioral disorders, all mental and behavioral disorders, neurotic stress, somatoform disorders, personality and behavioral disorders, developmental disorders, behavior, emotional disorders with onset in childhood. Absolutely no change. In fact, a slight decrease in the frequency of diagnosis. So does this tell us that lockdown does not induce psychological stress on children? No, it doesn't. This is, as I said, the first wave of the pandemic. And I'll show you some other data in a minute. So this is a study done in the north of Germany, the COPSI study, which shows you that compared to before the pandemic, at different times in the pandemic, with increasing duration of the lockdown measures, there is a continuous increase of psychosomatic syndromes, abdominal pain, lack of energy, fatigue, headache, sleep problems, irritability. They all take time to develop to a higher level. So the first wave of the pandemic is not what we really can conclude on in relation to the burden for children and adolescents. We looked at the same data, the doctor's diagnosis with the ICD codes, here only in the state of Bavaria, in the second wave of pandemic. Here we see a very different picture. If you look at the frequency of diagnosis of depressive or episodes and fear disorders, in the second wave of the pandemic, they're going up by almost 20%. And it's mostly the adolescents here. This is 15 to 16-year-olds, where they go up by 20%. So if the lockdown, the contact isolation lasts for a longer period of time, we really see a marked effect on child health. And this translates into suicide attempts. This is data from Germany from pediatric intensive care units treating children with attempted suicide. You see, the first wave of the pandemic, it actually went down, less suicide attempts. But in the second wave of pandemic, there was a marked increase. In fact, we had in Germany in the first wave a hard lockdown, in the second wave a more soft lockdown. But still, in the second wave, we had a marked increase, basically a threefold increase of children treated with suicide attempts in intensive care units, pretty similar for girls and boys. So clearly, it's not enough to just look at the short-term impact. We need to look at this longer-term evolution. So in summary, pediatric outpatient visits in the first pandemic wave decreased by about 1/5, mostly explained by less infections and less injuries. Diagnosis of chronic physical conditions and of psychological behavioral conditions hardly changed with the first wave, but not in the second. One conclusion is, if infection risks are modifiable to such a great degree, that we should look at opportunities to prevent infections even better in educational settings. Obviously, we don't want any lockdown anymore, never again for children, but we should clearly look at opportunities to reduce the infection risk, because we know it's not only inconvenient, but it has severe long-term burdens for children. Just think about loss of hearing from early otitis, and of course also adverse effects on families and parents. I would like to remind us all that all European countries signed about 30 years ago the United Nations Convention for the Rights of Children. I think the only one country in the world, Michael, that still hasn't signed it is the United States, but the rest of the world has signed it. And there's two important messages there. In Article 3, it says the children's well-being has to have priority in all public decisions. And we clearly did not respect that right when we induced the lockdown, the closing of schools, when adults went back to work again. And the second important message is in Article 24, the children's right of the highest attainable status of health. Also that right we did not respect. We should probably remind our decision makers to think of children first. So what have we seen? We've seen disruption of family life, fears regarding employment, income, limited or no access to daycare and schools, recreational facilities, market impact of physical sedentary activity, diet and beverage intake, psychosocial stress, with increase in suicidal attempts, increase in depressive episodes and fear disorders, and an increased risk of overweight and obesity, and an alarming increase of social disparity that we cannot afford, not from an ethical standpoint, but also not from an egoistic standpoint of our societies. We have a demographic change in Europe. We have a lack of young people contributing to society. We have shortage of workers everywhere. So just from an economic point of view, we cannot afford to leave a large portion of our children behind, not giving them an opportunity to fully use their potential. Key learnings: we must keep daycare, schools, and recreational facilities open under all conditions. Obviously, if there is a local outbreak of an infection, we can have a local restriction in one particular area, but we should never ever have a lockdown for all the daycares, all the schools. When we need prevention measures that effectively reach the total population, including high-risk groups, voluntary information strategies are not enough. We need setting-based prevention. We need the sugar tax. We need to have an obligatory food labeling like the Nutri-Score in Europe, and we need better banning of advertising of unhealthy foods. Thank you very much indeed for your attention.
Thank you very much. As a parent of 2 small children, I applaud the keeping school open all the time. We have some questions. Thank you.
Thank you for the excellent presentation. Just a reflection. So in Sweden, we had schools open, preschools open, and I have a poster here upstairs showing complete national data measure with preschoolers, and we see increased obesity with 30% during the pandemic.
So do you have an explanation for that? What?
No, I'm looking for the explanation as well, and we have an equal increase in bonus drugs. So that's.
Maybe I can ask you. I read an article indicating that while Sweden had not imposed many obligatory measures, people voluntarily have withdrawn from social activities in Sweden. Just because of the fear of transmitting infections. Is that perhaps happening also, and was restricting contacts for children as well?
That's a very good suggestion. We have another paper already published showing also social disparity, where we compare 3 different countries, Romania, Sweden, Spain, the same age group. So yes, but does that explain? I think by my explanation, I suppose that most people were really scared, and we had very high level of death in Sweden in the beginning. So that highest in Europe, because we reacted very late and closed borders very late, and I think that maybe has contributed to the overall distress in the society. But still, we have 30% decrease in Sweden among young children.
Thank you for the nice school. I'm really work with Netherlands. During the pandemic, I worked as a manager in pediatric obesity care center. And we studied as well these phenomena among our patients who were already in care for their obesity. So it's a different selection. And I can agree with what she said, that we experienced a lot of anxiety among children as well, not only among parents. Being anxious about what they would put their family to risks when they would go to school or to sport. So high stress levels, which also is a high risk for becoming obese or worsening of the weight. But hope, there was also some hope in our data that we collected, because we saw that some of the patients and families, despite their socioeconomic status, did better during the pandemic, and that were mostly the patients and their families who really had a strict day structure and were already filled with knowledge and information on what works to prevent becoming more overweight. So having the daily breakfast with the whole family and all sorts of patterns that they just continue. So I think even in this in between pandemic, maybe, hopefully not, periods, investing in healthcare and preventive measures also in families that are at risk were very helpful.
Thank you. That's an excellent point. We actually did also some some focus group interviews, trying to understand why, against our expectation in the first pandemic wave, we did not see any increase in mental disorders. And when we did the focus group interviews, we actually heard the same from many families, that there was sort of protective factors. There was less distractions for parents. Even if they were not in home office, they spent more time with the children because there was just nothing else to do except for television or screen activities. Couldn't go out, you couldn't do anything. So you couldn't meet with friends. So there was more interaction with the children, more talking with the children, which perhaps for many adolescents was not a protective factor, but for younger children certainly can be very, very positive, kind of positive effect. So it's a complicated picture. We cannot just say it's going in one way direction only.
That's a great talk, thank you. I've seen some reports of increase in type 2 diabetes in children. Although the child rate is quite flat. I've also seen some papers showing severity of type 2 diabetes more ketoacidosis. Do you have any more insight into that child data? Did we look at the type of diabetes and severity?
Thank you. We have not seen those effects. We are currently looking at the national data, the ICD codes for the later period, also the second and third wave. Maybe we will see it there, but we haven't seen it in the first wave. But mind you, we have only looked at the outpatient data. So if you want to look at ketoacidosis or other metabolic crisis, it's probably more in the hospital data than the outpatient data. Thank you for that.
Thanks for the answer. I'm specifically interested in the role of the family for development of obesity, and I was wondering, this was like we do not know that it's a great experiment to see if the parents are more at home, what happens when the children are more supervised. So, and I see some data that are both in the healthy direction and in the unhealthy direction. So what would be the final conclusion if families are more at home, the parents are more supervising the child? Should it have positive impacts?
I guess it all depends. So, as I said before, for the younger children, that's probably perceived as positive. If you're 15, 16-year-old and you're more supervised by your parent, you probably would not regard that that's positive in most cases. And we've clearly seen this big disparity in low socioeconomic groups, even if parents are at home and there's just the family in front of the screen is not communicating with each other, is not promoting healthy foods, it doesn't have necessarily a positive effect. So it is probably very much dependent on the circumstances. Like, we would conclude with the benefits of early daycare. At a very early age, the benefits are greatest for the most disadvantaged groups, whereas for a middle-class child, the benefit from early daycare is probably less easy to determine, but for a disadvantaged child, there's clearly a big benefit. So it's a complex discussion where we don't have a simple answer. I think the key conclusion, in my point of view, is we need to strengthen the measures that support the children who come from a disadvantaged environment and help them go a healthy pathway.
Okay, I think that's it for this session. So we have until 4:30, so it's an opportunity to move around and to grab a coffee and to see the posters. So thank you. convene at 4:30 for the second session. Thank you.
Hi everyone. Thanks for being back on time. Hello. So that we can start the session on time. So I'm very happy that Dr. Marie-Laure Frelu, who's one of the founder of ECOG and a past president, is going to chair this session. Sorry. Thank you. And so Dr. Marie-Laure Frelu is going to chair the session. She's, as I said, past president of ECOG and one of the ECOG founders. So I'm very happy. Thank you, Marie-Laure, for chairing this session. And this is kind of a special session as well, because as I mentioned in introduction, the National Health Insurance is doing quite a lot of things in France regarding childhood obesity. And we specifically have two kind of structure and organization. And the first one is called the Article 51. And someone from the National Health Organization is gonna present that. And first, so this is gonna be the French focus as an example of what we do here. But then first, we are very happy to have some people from the World Obesity Federation given an international focus, but I'll let Marie-Laure share the session.
So it's my pleasure to introduce Anna Bunzi, who was with the World Obesity Federation, who has nice projects and nice achievements, mainly in terms of childhood obesity and has it for years.
Is this one? Yes. Hello. So use both. This is for online. Okay. I can do that. Okay, well, it's nice to be here, and thank you very much for inviting me. I'm Hannah Brinston, and I'm the Director of Policy and Programmes at the World Obesity Federation. And today I'm going to talk about the two projects that we're involved with, but I'm actually going to do this in the context of the wider work the World Obesity Federation does. We're a civil society organisation based in London, but representing organisations all around the world. And I thought it would be a useful addition to the conference to talk about kind of a civil society perspective on what we're talking about today, over the next few days. So I will, you'll see the slide design will change. I will switch hats between being World Obesity Federation and then speaking about the two EU projects, but you'll know where we get there. So the World Obesity Federation, we're a global organisation. We have over 80 member organisations around the world and have just reached the milestone of representing 100 countries around the world. We've got a couple of inter-country alliances that have joined recently.
We work in 3 or 4 strategic work areas: global advocacy, capacity building, advancing knowledge, and convening stakeholders. And through these different areas of work aim to sort of shift policy, shift understanding, and shift the dial on obesity generally. I'm going to kind of focus on the first 3, which I think are more interesting in terms of talking about the activities that we do, but bringing together stakeholders on obesity, whether that's people who are from a clinical background, research background, civil society, high income, low income countries, etc., is really important and underlines a lot of the work that we do. We work across a range of different sort of thematic areas. The 3 that we prioritised for the current strategic period of 2020 to 2025 was childhood obesity, healthcare and health systems, and food systems. I've represented them as 3 separate boxes. Actually, these all really interlink. When we talk about childhood obesity, of course, we're also talking about health systems and food systems. But these are the 3 areas that we work in. So to talk a bit about the policy and advocacy work that we do, our goal is ultimately to have national plans on obesity, including childhood obesity, or obesity sufficiently integrated into broader NCD plans. In 2020, I think it was, when we launched the first collective World Obesity Day with a number of our members, we launched the Roots framework for policy action on obesity, which identifies some of the key areas that we prioritise when we're advocating for specific policies on obesity. For us, having comprehensive policies is really important to having an impact. So not just talking, for instance, about nutrition, not just talking about physical activity, not just talking about health systems, but talking about all of it together and seeing how those different areas complement each other. So the first of this framework is to recognise that obesity is a disease and therefore does need to be addressed as a disease within the health system as well as within the wider environments that we live in. And in January of this year, yes, this year's been very long. January of this year, the new WHO ICD-11 definition of obesity came into force and does sort of recognise obesity as a disease and therefore provides sort of backing for having more action in this regard. We also have an item on obesity monitoring surveillance, recognising the need to better understand the situation at a country level, which, as Criminal was talking about in Europe, really provides us with a lot more information about what's going on at a country level and also can help us tailor policies. Obesity prevention needs to be integrated. This is generally more strongly focused on within obesity policies, but obesity prevention as well as treatment of obesity needs to be integrated, and this is always within our messaging throughout the life course, so focusing sort of prenatal childhood obesity and then into adulthood and older adults. And then finally, that we need to take a systems-based approach for treating and preventing obesity. So these are the kind of things that we're looking for when we're assessing action plans and commitments to obesity. For us, the big policy priority at the moment relates to the new WHO recommendations on obesity, which you may be familiar with. These are comprehensive in that they include both prevention activities and management and treatment, and are importantly across the life course, focusing on both children and adults. So these were adopted at the World Health Assembly this year, and they recognise obesity as a disease. They're comprehensive, as I said. They draw on a lot of existing nutrition and physical activity frameworks that already exist, and also the Ending Childhood Obesity Commission work that was done 5 or 6 years ago now by the WHO. And they also include new recommendations on the treatment and management of obesity, particularly amongst children and families, and position the need for obesity to be included in universal health coverage and primary health care, that health professionals need better training, that we need multidisciplinary teams, and that stigma needs to be addressed as well. So for us, these recommendations are a really good reflection of the different things that need to be done to address obesity. And our next step, and the focus of the presentation, is more how we actually get these recommendations that we made at global level into national action on obesity throughout the life course. And as I said, then it complements the work that's been done specifically at WHO Euro level. So WHO has developed an acceleration plan which is supporting implementation of the recommendations towards the goal of having national plans on obesity, which are being done in a handful of countries. Our goal at World Obesity is to support the acceleration plan in those countries that have put themselves forward. In Europe, it's, I believe, UK, Slovenia, Portugal, and Turkey. But we're also working across the world and across Europe to support the implementation of those recommendations and make sure that governments follow through with the commitments that they've made. So that's just kind of an introduction to what our focus is. At various points, we've changed our focus to kind of reflect the broader political landscape. We've got the universal health coverage UN high-level meeting coming up next year. So that the focus of obesity within that will be a kind of a key priority for us. And then there's the NCD UN high-level meeting, which is in 2025. Which will then kind of be where we focus a lot on getting the implementation of this work. So then in terms of capacity building, this is also an important area of work for us. And by capacity building, we're really focusing on kind of education and engagement of different stakeholders. So we do this through a lot of our work, whether it's supporting our members, whether it's training healthcare professionals, or whether it's engaging particular groups of society, whether that's patients or whether it's young people. Many of you will hopefully be familiar with our Scope e-learning. This is a training platform that we have for healthcare professionals to get better education basically on treating, managing obesity in their settings. We have a core learning path, which is a series of modules that healthcare professionals can take to become scope accredited, as well as a number of other modules that have been developed. We work with various partners on these. So for instance, World Heart Federation, we've got some clusters specifically on heart disease. And we have worked with ECOG specifically on a childhood obesity package of modules. And these are really important for bringing together education on training for obesity. We know that at present, a lot of medical training doesn't include obesity. And it's really important that we recognise increasingly that that needs to be addressed within health services, that the health professionals are adequately trained, and that's what we're trying to do through Scope. Marie can probably comment a bit more on that, but we can say that. So then this is where I switch hats and I become co-create. As part of one of our EU projects, we've been doing a lot of work engaging young people. And when we talk about childhood obesity, we do a lot of talking about people, about young people, about people living with obesity. But actually, we do very little talking to young people and talking with them to understand the problems that they see, the experiences they have. And this is one of the things that the Co-Create project was hoping to address and move the dial on, not just actually in obesity, but across public health. And a number of the recommendations that are going to come out of the project will be relevant whatever area you work in. So the Co-Create consortium is made up of 14 partners at WHO Europe. And it's a 5-year Horizon 2020 European Consortium project. So we're just approaching the final year of the project, which means that we've got lots of exciting outputs that we can be talking about. I don't know if you can see all of the detail of this, but basically the format of the project was looking first at the policies that are available, the evidence for research, and mapping the systems that we live in to try to identify the different areas of priority for the prevention of childhood obesity. The available policies are currently hosted by the World Cancer Research Fund International using their Moving and Nourishing databases, which you might be familiar with, and that includes details of national policies that have been implemented. We then have done a lot of research on the evidence for the impact of these policies, and then the systems mapping have been done with young people. So we did group model building, where we were working with young people to identify their experiences and the systems in the areas that they live in order to identify and see how different policies feed into each other and how to prioritize actions moving forward. The core part of the project has been the series of activities that have engaged young people. So this started with alliances in 5 countries in Europe, where we worked with young people in different ways, but basically discussing with them what their policy ideas are, what their priorities were, and going through a series of iterative discussions about how to refine those policies in order to have recommendations. Interestingly, there was quite a range of recommendations, as you can imagine, but actually a lot of what we would talk about, things like marketing, education within schools, physical activity, etc., were things that the young people were aware of and wanted to see action taken on. So it's good that when we're talking about those areas that we know that they are also what young people are experiencing. As part of this, we also established a dialogue forum process, which I'll talk a little bit more about in a minute, but that's just basically a system to, or process by which to engage young people actively in the discussions with the key stakeholders who are actually more focused on implementation, whether that's policymakers, civil society, businesses, etc. And then the process that we're in at the moment is the kind of evaluation stage. So we've got the policy ideas from the young people and we're looking at the impact that they could have. And the idea here really is that we're co-creating policy recommendations with young people and engaging them in the process, both from a research perspective, but also policy and advocacy perspective. So the dialogue forums, these were developed as part of the project with EAT. And they're an opportunity to discuss with others, discuss ideas and collaborate, basically. And it's a process, it's like a roundtable workshop is the format that it takes. You have 6 people at a table, 50% at least are young people, working with stakeholders, looking at a policy idea, refining the idea, discussing kind of options, challenges that people see, and then identifying commitments that the people at that table can make towards that policy based on the area that they work in. For young people, it's an opportunity to get feedback on the relevance of what they're doing, to connect with the decision makers at a national level. So a lot of these dialogues have been done at a local level where the alliances are set up. So people have direct contact with, for instance, people that are maybe making city level policy decisions and things like that. And also helps young people to get a better understanding of the policy issues from different perspectives. So making sure that when we're engaging young people, we're not just asking them to come up with ideas and then sort of taking them forward and then behind their back saying this isn't going to work, or this doesn't just fly. It actually is a process of working with them to understand their decisions and how we can actually address it. And for us as a project, having young people involved and getting their recommendations helps politicize the issue, empower young people, and hold intergenerational dialogues, which, as I say, was a key part of the Co-Create project. Off the back of the work that we've done with young people, we set up a youth task force, or I say we set up, it was led by a number of the more engaged alliance members, and I think was particularly important during COVID as a way for them to continue engagement when we couldn't necessarily go through with all the in-person plans that we had had. And basically through a series of discussions, the most engaged young people met, they talked, they went through their policy ideas, and I identified 4 key areas that they wanted prioritized in policy to help prevent childhood obesity, including the ban of marketing on unhealthy foods, high quality practical based education in schools, implementing sugar and sweetened beverage taxes, and the provision of physical activity. So young people have come up with these and then we've integrated them within the recommendations that we make as a project. And we also have finally a website which we're used to support young people with their advocacy. So to empower them both with knowledge, so providing them with background information on childhood obesity to help them make decisions based on research and wider knowledge, but also providing them with tools to help them advocate at a national or subnational level to make sure that we have a kind of long-lasting legacy of the project. So we're not just engaging young people, having a discussion, analysing their inputs, and then sort of leaving them. It's about creating that long-term engagement mechanisms, and we're doing a lot of work to give them opportunities to kind of get young people actually engaged more actively in policy. So that's the update that I wanted to give on Co-Create. I'm going to put my World Obesity hat back on now. and talk a little bit about how we advance knowledge on obesity. So when we talk about knowledge at World Obesity, that includes a range of things from data and evidence on obesity, on the research, on policy impact, sorry, but also around issues such as stigma and trying to address some of the misunderstandings and some of the biases that exist on obesity. And we try to do a bit of all of this, depending on who we're talking to when we're talking to them, integrating it into things like the World Obesity Day campaign. So so we've already actually briefly touched on the economic impact of obesity. For us, this is really important for trying to make the case for addressing obesity, not necessarily to the health ministries, but to others who make the decision. We know, for instance, that a lot of the big discussions around taxes and things are going to need sign-off by the finance department because it's a tax issue and it's not necessarily always seen as a health issue. So making the economic case for action, we believe is really important to try and get cut through. And really we focus this around the impact and the cost of inaction. So it's not about sort of saying that people living with obesity are a burden or anything like that. It's really about the impact of inaction. So if we don't do anything, what are the potential costs? And our data looked at, so we did a pilot, it was a pilot work that was done, published at the end of last year, and then last month published the data for 161 countries around the world using methodology, which you can find on our website. And basically the data showed that the economic impact was estimated to rise from 2.19 to 3.3% of GDP across the countries, and that there could be a global annual saving of 2.2 trillion if overweight and obesity prevalence remained at 2019 levels. So we're already starting to, I guess, weaken in a way the targets, because the targets that Grimna mentioned earlier were for 2010 levels. So we're already readjusting what targets we want to meet, but that's because we are so far off. But ultimately, if we need to halt the rise in obesity, and we can continue to get savings if we do so. The biggest increase in cost concentrated in lower resource countries, which is not unexpected for many reasons, and the countries expected the largest economic cost of overweight and obesity are China, the United States, and India. We have all of this data on the World Obesity website, worldobesity.org, if you want to go into the details for each country, which you can do, and look at the differences in different years. But I think this can be a great resource for taking kind of action and creating the rationale for action at a national level. So this data is hosted on the Global Obesity Observatory, which many of you are hopefully familiar with. And on this, we provide data on a range of different data points related to obesity. So we do have prevalence data for adults and children, boys and girls, but also have a database on comorbidities, different socioeconomic groups, education levels, etc. We have policy databases on there, contextual factors, economic status. We have a lot of information on this website, and there are mechanisms by which you can pull together information, and that can help, again, make a case for specific actions at a national level. And this is the role that, as World Obesity, we try to play, is facilitating national kind of advocacy to help identify the need for change and to communicate that with the decision makers. We also have a set of policy dossiers, so these are focused on a number of different policy topics, where we've collated things like systematic reviews, guidance documents, case studies of successful implementation. We have a briefing paper, cost studies as well, and we've basically collated some of the most recent and important documents as we see it on each of the policy areas. I don't know if you can read them, they're actually very clear. We cover topics such as SSB taxes and digital marketing, city-level interventions, pregnancy, the treatment of childhood obesity, front pack labelling, as well as food systems and weight stigma, which was done in a slightly different way, but again has the evidence. And we use this again to support people who want to try and make changes at the national level, to support our members with advocacy by providing that evidence, and also when asked policymakers who want the evidence for the actions that they're being asked to take. So again, this is all on our website. So then another part of what we do is supporting research. And while we do a little bit of research at World Obesity, for instance, with the economics work, a lot of what we do is about translating the research. And that was kind of why I wanted to talk about what we do at World Obesity, because I know a lot of their program is focused very specifically on the research that's coming out. What we do is try and consolidate that and look at how we can actually use the evidence that's coming out to stimulate action and raise awareness about the issues and what we know. So as part of this, we engage with a number of projects and support them with exactly that, the knowledge translation, one of which is STOP, which is another Horizon 2020 project, which is coming to an end at the end of this month and focused on childhood obesity policy, particularly looking at the determinants of childhood obesity and various policy responses that are required to address childhood obesity in a comprehensive and holistic way. So you don't really need to see this. This is all of the consortium members. I know there are a couple of people in the room who are also involved with the STOP project. We have a range of research organisations, national institutes of public health, civil society, business-related organisations, and international organisations involved in the project who have been involved at different parts and in different ways. The way the STOP project has been structured is to look at how we can measure childhood obesity, looking at the trends, looking at what the patterns are in terms of which socioeconomic groups have a higher risk of obesity, whether urban and rural communities have a higher risk, and looking at the factors that impact on that. We've done a lot of work on the key determinants of childhood obesity, including work on things like the exposome, epigenetics, the impact of neighbourhoods, ultra-processed food, all sorts of drivers of obesity that are maybe not at the forefront of what we talk about when we talk more about the outcomes. We then looked at the different policy areas that can be used to address childhood obesity, including regulation and fiscal policies, consumer behaviour, healthy food and food choice, environment, physical activity, and healthcare. And from these have developed policy recommendations, which we hope can help advance childhood obesity policy in Europe and also around the world. In addition to this, we've also done policy analysis, and we've done a lot of work on multi-stakeholder action, looking at the role of different stakeholders at different perspectives and how we can collectively work together while making sure that we minimise conflicts of interest in the policymaking process. Some of the key outputs from STOP, aside from the specific pieces of research and policy recommendations, are new evidence on the impacts of policies and interventions and the evidence on the determinants of childhood obesity. And understanding the determinants is so important for making sure that we're targeting policies in the right way from a prevention perspective. A comprehensive set of indicators and a measurement framework for epidemiological surveillance, policy briefs and toolkits for the design and implementation of the key policies, and a new criteria for supporting multi-stakeholder frameworks, as I say, to help minimise conflicts of interest and maximise impact. We've published 2 STOP supplements. Actually, these are in the wrong order. The first one was on policies to tackle childhood obesity and included a number of systematic reviews of evidence for policies to address obesity, including recommendations, and I think in most papers an emphasis on the equity dimensions of the policies. We also published at the beginning of this year a supplement on the determinants of childhood obesity, which looked at, as I say, a number of papers around the role of neighbourhoods, prenatal exposures, epigenetics, ultra-processed foods, and obesity risk and outcomes. And this was published, as I said, at the beginning of this year and consolidates a lot of what we found in the project. And we're now looking at what recommendations specifically come out of that. A key output that we have is a set of policy briefs that we worked on with WHO on a number of the key policies that we've focused on across the project, including nudges, reformulation, nutrition labelling, marketing, fiscal policies, and the physical activity. And what these briefings do and how they differ from other documents that have come out from the WHO and others is that they really focus on practical guidance for a policymaker. So a policymaker has already identified this as an area that they want to take action on, and there's various case studies and guidance on how that can actually be implemented in practice, and some of the obstacles that they might come across and how to overcome them. So for instance, on the marketing one, there's some examples of some of the industry lobbying that you might see on the topic, and ideas of how you can actually counter that. So these are really practical, and we've had really good feedback from policymakers on using these, and we hope this will be one of the areas of kind of long-lasting, as I say, legacy of the project. And that's just a nice picture to remind me that I'm stopping on the stop stuff. This is the consultant. So then finally, I just wanted to talk a little bit about World Obesity Day. So many of you may be familiar with World Obesity Day. In 2020, we launched kind of new rebranded World Obesity Day. This was following kind of the recognition that we had a World Obesity Day, that our member, who we work very closely with, the European Association for the Study of Obesity, had a European Obesity Day, and various other members around the world. And we decided that actually the best way to have the highest impact was to come together and have one World Obesity Day where we all collectively talk to the same messaging and then go away and tailor the messaging for different areas. Our focus of World Obesity Day is generally on action. We provide a number of kind of broad tools for everybody to use, but we really encourage people to tailor the messaging and to take action that's relevant where they live, whether that's based on the prevalence or the political will, whatever national contextual factors are there, taking the message home in a way that will have the highest impact. And we encourage everybody to get involved. It takes place on the 4th of March every year. And information about the 2023 campaign will be available in the next couple of months. So yeah, that is my presentation. I hope that was an interesting insight into what we do. And yeah, thank you very much for inviting me again.
Thank you for this. Right, you are good. For the Obesity Federation, so are there any questions? So first, I may work with the Obesity Federation endorse some national program. Is it part of the policy that we may a more visible label?
You're asking if we endorse them?
Yes.
Typically, we haven't. Well, typically, we haven't, but we have, where we've worked in partnership with people, we have kind of had an element of that. Our actual endorsement process is something that we're reviewing at the moment to see how we can take that forward, recognizing that increasingly there's interest for this. What we've seen is that in the Latin American region, South America, there's a lot of emphasis put on the role of civil society and how important that is for driving forward policies. And increasingly, we're kind of seeing a little bit of that more in Europe. So it might be something that will increasingly be seen in the future.
Thank you. So I have a question about the co-create project and one little result that surprised me. You highlighted the fact that the led to policy putting forward tax on sugar-sweetened beverages. I'm a bit surprised that Delhi's himself put forward this policy. So I was wondering how they were selected to participate in these groups, and what was the process leading to this kind of report?
Yeah, no, that's a fair question. I think the fact that that was included was more representative of the information that we were providing them with. So showing what the recommendations were already in place and looking at them to kind of challenge that and critique that. The actual young people themselves, it varied across the countries. So I think in the Netherlands, there was a big focus on going into schools. In Portugal, there was a big focus on going to scout groups. I can't remember for the other countries how they were selected, but it differed in terms of how sort of represented they were. Clearly, there was an element of they had to be engaged, but we did try not to just go to, for instance, youth organisations and those who were already advocating on health, to make sure that the engagement that we had was kind of a meaningful representation. But the young people, I think if I remember correctly, there was 29 policy ideas. These were just the ones that became refined from the task force.
Very nice. A small question. Is the publication of talk results an open paper journal?
Yeah, so yes, so the STOP articles are all open access, or should be free access at least. And everything that we do at World Obesity, we make open access to make sure that everybody has access to them. Yeah.
Thank you, Hannah, for a very comprehensive and inspiring presentation. I've been involved in the STOP project, and I'm kind of amazed of all the pushes from you to us to kind of translate our research funding, make it simple. So I mean, being part of it, because just to put it in perspective, Concrete and STOP were the largest European project funded, and it's 10 million euros. So these are huge projects, and you have to be charged with dissemination that is both of them. So what messages do you have to us researchers when it comes to disseminating the research funding? What have you learned over the years? Because yeah, you have a lot of experience.
Yeah, thank you very much for that question. I think for us, we have, as a civil society organisation, we have a lot of frustration that a lot of great research goes into academic journals and stays in academic journals and doesn't leave that. For us, when we're communicating outside of academia, that's not going to be the way that has an impact, both from a policymaker perspective. They want to know that there's evidence, but they want to see it written in very simple ways of how that's actually, what does that mean? How is that implemented? What does that mean for them? And putting it into lay language for a range of audiences. So that's one point. And the second point is thinking about who is actually going to take forward the messages that you come up. If you're doing great research on something that has policy implications, who is actually going to be communicating them? Actually, civil society. Civil society is probably going to be the best bridge between the research and the actual policymakers themselves. So again, I would think about what would a civil society organization likely need in order to take forward that research. So it's all just about thinking, what do you want someone to do with that research, and thinking about how you can communicate that. As I say, World Obesity has a lot of sort of mechanisms by which we can help to share that and elevate that amongst our own contacts. So it's okay to not have the answers, but I would encourage everybody to reach out to those that might, whether it's World Obesity, EASO, other groups who are working in this area who actually have the ability to communicate to our wider audience. Getting your physical activity in.
Thank you very much for the presentation. Thanks, so usually policy are targeted to nutrition, physical activities, but do you think there is a room or possibility to implement on different other competence targeted on sleep, on psychosocial competence, on self-confidence or other aspects, because we know now that we have to enlarge the targets. So what do you think about that?
Right, I need the. I don't know what I need to do. So. I mean, I think it's a great point generally that we do a lot of talking around physical activity and a lot of talking around nutrition. And we know there are a wide range of drivers and solutions to obesity that we need to better integrate. Where I think we're maybe lacking from a strategic perspective, I guess, is really identifying who can take that action. Is it healthcare professionals? Or which ministry is it? Is it the health ministry or is it another ministry? And really making sure we're clear in who we're targeting. So for instance, physical activity even is a good example. We often talk about that within public health, but a lot of what we're talking about is physical activity in schools. Well, the people who make the decisions about schools are within education. So I think we need to be much more strategic about thinking outside of health, recognizing it as a health issue. And this isn't just unique to obesity. I think this cuts across a lot of health areas where the solutions are not necessarily health solutions. They have a health benefit, and we need to find ways to communicate that. And I think that's where data such as the economic data can be quite useful, because it makes a case outside of health data, which everyone understands economic kind of cases because they're always thinking about it from different perspectives. Health data maybe doesn't resonate as well with sectors outside of health. So looking at how we can be creative in what we communicate, it's going to be really important moving forward.
So thank you very much for this nice intervention. And I'm inviting Dr. Tzadoni to present us the national health policy issue. Thank you very much.
Thank you. So, thank you very much. Thank you for this invitation. We're delighted, although the National Railway System tried to prevent me from being here. And thank you, Hannah, for being accepted to swap the presentations, because I just arrived just before the presentation in this session. So sorry, I couldn't be present for the whole day. I'm going to talk about things from a very different perspective, because I present myself. So I'm a medical doctor specialized in public health, but I work at the National Health Insurance Fund, CNAM, in France. We cover 95% of the French population. So we are a payer in the system. And I'm the deputy director for the strategy, surveys, and statistics at CNAM. So we do a lot of research, evaluation, also trying to improve the care in the system and the efficiency of care. So we have, of course, efficiency focus on our policy. So what I'm going to talk to you about is something that is quite new in France. It's been implemented in 2018. It's called Article 51. So the Article 51 relates to the article of the law that implemented and enacted the framework. But it sounds quite nice, because those of you who are familiar with UFOs find it Article 51, because we sometimes do bizarre things and innovative things. So that's why the name stick to the framework. One way to talk to you about is why it has been implemented, how, and what type of projects we lead in this program, and specifically projects relating to obesity and child obesity. So I'm going to have a wider focus at the beginning of my presentation, and then I'm going to actually focus on obesity and child obesity. The first thing you have to know is that I have no conflict of interest, apart from being salaried from the National Health Insurance Fund, but I think that's quite common to start with this type of slides. So what is Article 51? The main idea is that when you have a new drug, you can market the new drug. There are a pathway for new drugs to come to market and to be prescribed and delivered to patients. But when you talk about organizations, we need to change organizations. You don't have pathway. You don't have an organization to have new organizations to evaluate. So Article 51 is precisely designed for that. When you want to change the organization, you want to make something new. And when I talk about organization, I talk about skill mix in the care organizations, how people work together, how you share competences between doctors and nurses, how a new technology affects the way people are organized and they take care of the patients, how care delivery is organized. Everything around this is care organization. And when you want to change it, usually it's very difficult, because care is regulated. You have laws and regulations that say what you can do, what you cannot do. And also payment mechanisms affect strongly the way organizations are functioning. So sometimes, and most of the time, when you want to change an organization, you are affected by the way the payment mechanisms prevent you from doing a certain number of things. And when you want to change it, then you must be outside the law. In France, it is the case. So it's very difficult to change the organizations if you want to go beyond what's accepted by the law. Article 51 is made for that. You can breach the law easily in order to try new organizations, new payment mechanisms, but they must be evaluated. And if the evaluation says that the organization is good, then it might be implemented and scaled up. That's the whole process of Article 51. That's the whole idea. Those of you who come from America might know the CMMI, the Center for Medicare and Medicaid Innovation. This is something that looks like what we're trying to do, but there are other frameworks like that in Germany, also in the UK, which we work a lot with. And to say that we are not alone to do that, but we have a certain number of characteristics that I would try to define and discuss here. The first thing to understand is that new models of care and payment mechanisms we try, they are stemming from the front line. So any healthcare professional, any healthcare organization can propose a project, and this project might be funded if it is eligible to the framework and if it's deemed relevant in terms of its objectives and in terms of how it's designed. So it's a very open framework, which is not the case, for instance, in the United States, where mostly the frameworks that are tried by CMMI are designed by Medicare and Medicaid centers, and there a call for action is made for frontline professionals. So it's a very bottom-up framework that's been designed, which is interesting because we know that the ideas stem from the front line and not in the offices of any insurer or minister, whether it's Minister of Health or any other minister. So of course, it's not enough to have an idea, because usually if you have an idea to change your organization, you're confronted with a number of issues such as cultural organization, skills of the professionals, change opposition in many organizations, and therefore the experimentations must be supported. Because most of the time, people come up with an idea, very clinically centered, and when you have to change the organization, for instance, you have to change the schedule of some staff, or you have to say that nurses are going to do that the doctor was doing before, then you have to be supported in order to implement your project. So support is very important, and we use collaborative methods so that we come from an idea to a real project and an implementation of a project. It's very important in the process. Every project I told you is evaluated, and this is something that is very particular to France. I'm going to show you in the next slides what that means to have every project evaluated. And we have three main dimensions which we always look at when we evaluate a project. The first dimension is feasibility. It means, does the idea, if it was a plane, does it fly? Does it actually happen on the front line, or is it still on paper? That's very important. A number of projects are experimenting difficulties to being implemented. And it's very interesting to understand why a good idea, it doesn't come from an idea to the implementation. And sometimes you have to look at qualitative methods, usually not quantitative methods for that. The second dimension is impact. Impact can be clinical impact. It can be medical economic impact. It can be financial impact, and though we're trying to look, does the organization that is tried, that is experimented, actually produces the impact it says it will produce. And the third dimension is probably the most important, is reproducibility. Usually, it's the external factors that make an organization able to be spread in another place. The question is, does the organization exist in one place because of Dr. A, and only because Dr. A has a lot of charisma, because he's able to bring all the people with him? When you make the organization in another place, then it doesn't work. And therefore, the idea is to clone Dr. A if you want to spread the organization, or you try to understand what are the characteristics of the organization that make it work in one setting, and therefore you can put it in another setting. It's a very important part of the evaluation, because most of the time you have small scale experiments, they have interesting results, sometimes very interesting results, but when you put it in a wider scale, then you realize that they don't work at all because you haven't figured out why it did work. And the other dimension, which is very important also, is the medical economic impact, and the medical economic aspect. The business model of this organization is very important. We had a number of experiments in France which were very interesting on the clinical level, but they were very, very expensive, and they could not be put at a wider scale. So From the start of the experimentation, we try to look at what is the business model and does it fly at wide scale. And this is very important. And I think that's probably where most experiments and good ideas die, because they are not able to be put on a wider scale. And I shall give you some hints on that in the next slides. Of course, the idea of all that is not to experiment, is to find new ideas to change the regulation of the system and to promote new organizations. So scaling up is always at the heart of our reflection. We are not a research and development framework. This is a framework of transformation of the healthcare system. So always have the question in mind: what do we need to change wide scale? What do we need to change in the law? What do we need to change in the regulation in order to this specific organization be promoted or implemented in another city? In order to be eligible to the Article 51, I said that everybody can go forward with an idea. It can also be a patient organization, for instance. That happens, we have some. You must at least have two main eligibility criteria. The first one is you must require a legal derogation. That means that if you can do what you want to do with the actual regulation and payment mechanisms, Article 51 is not for you. But if the payment mechanisms or the organizational regulation or the law prevents you from doing what you want to do, then you are eligible to Article 51. That's very important, because that's a criteria that is really important to enter Article 51. And the second criteria is you must have an organizational purpose. We're not doing clinical research. We are doing applied research on health services and how health services are transformed. And that's very important. So if you don't have an organization side to your project, then it's not Article 51. Virtually, as I told you, if you look at what exactly organization means, that virtually every project has an organizational impact. So it's not very strict as a criteria. Legal derogation is probably more strict. So that's the whole process. Now, where are we now? So it was enacted in the law in 2018. So as of today, say call of the 1st of September, we have 122 projects on the French national territory. We have 3 projects that are already finished. And we give you some details about these ones because the first 2 were failures. And it's very important to understand that in that sort of framework, failure is a part of the process. And there is a lot of things to learn about failure. And so if you have an experimental framework where 100% of project are success, then you are not doing experimentation. You are doing maybe publicity to your project, but you are not trying actually things. And therefore, evaluation is very important. The three experimentations out of 4 have an impact on primary care settings. It might be GPs, it might be nurses, it might be specialized organizations. And I'll go for Obesity, I'll give you some details about it. But it's very on primary care, while some projects can also have an impact on hospital care and also social care. And most projects have an impact on both sectors. We have a lot of projects that have an impact on primary and hospital care. And this is very important because we have 2 regulations, one for hospital, the second for primary care. And when you want to make a care pathway involving hospital and primary care, it's always very difficult to implement. And Article 51 is very fit for that sort of experiment. The overall budget of all these experimentations is about a little above 500 million euros over the course of these experimentations. That seems quite a lot, but if you look at the budget of CMMI, for instance, it was $3 billion for a course of 5 years. So it's not few, but it's not that much actually. And the most common payment mechanism that is experimented is bundled payment for care episodes, which is something that we cannot do in the common law in France, and especially when a care episode involves actors from different sectors. For instance, if you want to pay with the same bundle of care, a hospital and a primary care home, then actually in the actual common regulation, you could not do it. In Article 51, you can try it and you can understand how can you make it, how people are dividing the money between them, and therefore it's very interesting to have this possibility. We have other mechanisms at trial, such as capitated payments in primary care, pay for performance, and of course, a lot of the models are mixed. They have a part of capitated payments, pay for performance, or bundled payments. If you take all the experiments, we have a global population of approximately 1 million patients that are affected one way or another by these experimentations. The two most common population targeted in the experimentation is, and it would be no surprise to people who are familiar with to public health and healthcare indicators, elderly patients and frail elderly patients particularly, and people affected by chronic diseases and most of the time multiple chronic diseases. So that makes a wide, broad scope, but of course, these are not the only populations that are targeted, and we have projects on general population or project targeted on people who are living with disability, mental health, or people exposed to specific certain risk factors, and I could give you some examples afterwards. So that's a huge program, and you see that we are not limited to one scope of pathology, one scope of organization. We are ranging from a wide scope of organizations that are tried, and it's very interesting because there is a lot of common difficulties when you want to implement a care pathway for, let's say, bipolar disorder, obesity, or prevention of cardiovascular diseases, because it's the same organizations, it's the same healthcare professionals, and there is a lot to learn about cross-fertilization between those projects, which makes sense as to why we have such a wide scope of projects. So what happened when I told you scaling up is a very important issue for us. So the law requires that the experiment cannot be longer than 5 years. But actually, most experimentations are shorter. The median duration is 39 months. Certain experimentations can be, the duration can be extended, mostly because we have the impact of COVID, which COVID-19 affected the number of experimentations, so they have to be extended in order to cope with that. But basically, after experimentation, you have 3 different types of outcomes for the project. The first outcome is we need more experimentation because the field of experimentation is too small. We have only one, for instance, we have only one organization. We want to have a wider and more diverse scope of experimentation, or we have 2 or 3 experimentations evolving around the same type of interventions, and it sounds interesting to mash up these experiments to make a bigger one and a more comprehensive one. So that's one type of outcome. Then we need a new round of experimentation. The second is the fact we consider regarding the evaluation that the experimentation is interesting and it must be scaled up, implemented in ordinary regulation. Then we have 2 types of strategies. The first one is we scale it up progressively with a stepwise approach, saying we start with a number of early adopters, and then we have a second wave and a third wave, etc. And that's a progressive approach. That's one I'm going to probably discuss afterwards. And the second is a global scale-up strategy. We say, okay, this is cool. We need to change the law. We change the law, and the law applies to everyone. The total strategies can be applied, for instance, for telesurveillance in France, because the law now has implemented telesurveillance in the general regulation. So it's becoming common law for everyone, and therefore it's not anymore a derogatory measure. But regardless, whatever you want to do, you must have a scale-up strategy, because it's not because something is in the law that it is applied. Because a lot of the times, that's why it's so important to experiment, to understand. You need to train people, you need to develop new skills, you need to provide them with tools in order to favor the adoption of all these organizations. So it's very important to understand that scaling up is a whole process. And it's not only because you said we evaluated the project, it's good, that it's going to spread. No, you have to support, probably much more supporting the scaling up of the experimentation rather than the experimentation itself. And of course, in all cases, and specifically in the third outcome, because I told you that experimentations can be failures, and therefore, if they are failures, then they are stopped. And of course, even if they are stopped, you must support the experimenters, and also you must make sure that the patients who are taken care of in these experimentations have a care continuity and be addressed to other setups. In any case, and that's the blue brick you can see in the middle of the slide, capitalization and learning from all of this is very important. Sometimes you learn more about the failures than you learn about the successes, and it's very important. So we have a lot of work on capitalization to understand. For instance, a number of projects have difficulties to recruit patients. They have a target of 100 patients and they come up after 6 months with 50 patients. And therefore, it's very important to learn from other organizations, to say patients are not going to wait in front of your organization. You have to look for them. You have to have a strategy to recruit patients. And what is being learned from a failure of another experiment is something that can be fed into another experimentation. And therefore, this cross-capitalization process between experimenters is very important, but also in public policy, because what happens at this level happens when you implement national policy, and therefore the support you need for experimenters is also the support you probably are going to need when you are going to scale up that sort of programs. Now I'm going to focus a little bit on obesity and overweight, which unsurprisingly is quite frequent in the experiments. We have 11 experimentations. Sorry, I have this little audio tag in front of the title, but we have 11 experimentations in Article 51 that specifically address overweight and obesity. All these experimentations, they target overall 11,000 patients, and the global budget of these experimentations is between 30 and 35 million euros. So that's a lot. And we're talking here about pilot projects, we're not talking about scale-up projects, indeed, because probably if we'd scale up, there would be more patients to be targeted and a more important budget to be had. We can divide the experiments in two different sections, while approximately roughly half and half. 5 experimentations target specifically children obesity. And we, as you can see, I'm not going to describe every of this experimentation. If you want to have a closer description, all the specifications are available online. But what you see, these experimentations can be in a specific setting in one French region, or they can be national, involving different regions. So they have a very different size and scope, but they range for child obesity. From the experimentation Pralimab is screening of overweight obesity in secondary school classes. So we are very early in the stage of in the course of the disease. So it's led in Guadeloupe, French West Indies. MRTC Mission Retrouve ton Cap is about preventing obesity. I'm going to talk to you a little more at length just after. So I don't talk too much about it now. We have also PROXOB, which is I classified it in child obesity program, but also it's a more it's a wider program because it addresses the family approach of targeting overweight and obesity. So it's centered on the child, but it involves also the family. So I think there's going to be a session which is going to be discussed probably tomorrow. So I have the very good to talk to it about it. So much better than what I can do today. We have also treatment approaches. And also Obesity, which is the national experiment about the treatment of severe obesity. So you see that we cover the whole scope coming from screening, prevention, treatment of mild forms of obesity, treatment of severe form of obesities, and therefore these experimentations probably are going to be blueprints for national policies, provided that the evaluation says that they work, they have a good impact. More rapidly on adults, we have 6 experimentations and half and half about surgical treatment of obesity. We have a high rate of surgical obesity in France, probably too high regarding the comparison with other countries. So we have 3 experimentations. I spare you the names, but roughly they are about a bundle payment before and after surgery, because in France we reimburse the surgery, but the follow-up of patients after surgery is not that good. And the number of things that are recommended in the best practices that are not reimbursed, and therefore these projects with mild variations, they try to address this issue. And 3 other projects on medical approaches for adult obesity. Once again, I spare you the names, but just to, if you want to look for the specification, you have more information. And they have a mix of treatments, interventions, digital tools, etc. And I can give you just afterwards a number of common points and viabilities in this experimentation, sorry. So the common points of all these experimentations is that the bundle payment for care pathways or episodes is the mode of the payment mechanism that is implemented for these experiments. They all have some measure of bundle payment. These bundle payments include care coordination, include services not usually reimbursed in France, psychologists, dietitians, physical activity. These are things that are recommended but not reimbursed today. They also are on a long period because their care episodes typically 2 years long, which is not exactly the type of things that we're used to reimburse. And they combine pluridisciplinary personalized care pathways and patient education. Also, they rely strongly on IT and shared IT between all the stakeholders of the organization. And there is also a lot of variability between those organizations. For instance, some of them focus on structuring the primary care networks around the patient in a territory. Others are specifically in partnership with the education administration. Others involve patient relatives and their family. And therefore, we have also a wide scope of topics that are addressed in these experimentations. I go very now quick about the experimentation Mission Autour de ton Cap, because it was the first experimentation that was ended. It was evaluated. It's been evaluated positively, and I give you some details about that. And now it's being scaled up in France. The decree that authorizes and describes the organization of Mission Autour de ton Cap has been published on Monday, so it's quite recent. So the idea is to propose an early onset and pluridisciplinary care bundle on medical prescription tailored to the children and family needs. So that was the experimentation. It was provided by healthcare professional psychologists, and there was habilitated healthcare organizations that were involved in the experimentation. In 3 French departments, Nord-Pas-de-Calais, Seine-Saint-Denis, La Réunion, and the experimentation lasted between February 2018 to December 2020. It started before the Article 51 framework existed, but it was integrated in the framework and evaluated according to the framework. So the population was children between 3 and 8 years old. They were overweight or at risk of obesity. They were not obese patients. They were not supposed to be. We'll see in evaluation that actually this is not exactly what happened. The prescribers were GPs, pediatricians, and GPs practicing in PME. So I don't know. Sorry for the foreigner, but PME is protection maternelle infantile. So these are semi-social medical care that managed by the departments, but basically these are GPs and pediatricians that are working in it. They have different settings, different administrative organization. They are supposed to screen, prescribe, orient, and coordinate the care of the child. They include in the organization. The effectors, there were 47 habilitated organizations. I don't give you so much for that. And the care bundle was about 2 years. 1 year, you have 3 assessment sessions with dietetics, psychology, and physical activity assessment, and 6 follow-up sessions, including nutrition and psychology. And the second year, you have 12 follow-up sessions of nutrition and or psychology. That was what was the specification of the experimentation. Now, if you look at the evaluation, and the evaluation report was finalized in July 2021, you have the link if you want to have more details about the evaluation. What's interesting, we have a mixed method. So we use qualitative and quantitative approaches in order to answer the question, is it feasible? Does it have an impact? How is it reproducible? And the actual end question is, do we want or not to generalize it or to scale it up? What the evaluation showed is you have an uptake that was interesting. More than 2,000 children were included. They were in the age scope. 60% were girls. And you have a little above 1,000 prescribers, so that in terms of feasibility, it was obvious that it did work. But one interesting thing is that 70% of children included were already in a situation of obesity at inclusion, which should not happen if the specifications have been respected. And what we realized is that basically there was so much needs for these patients that prescribers used the organization for a little wider scope than what it was initially designed for. But nevertheless, what's interesting, it improved healthcare access. You see, I don't know if I have some laser here. No. In 9 cases out of 10, it was the first time the family of the child had access to such interventions, although they were at risk. So in terms of care access, it's very important. Well, the results were very interesting. And also children with backgrounds with vulnerability, economic and social vulnerability were more frequently included, which were, of course, one of the goals of the experiment was to reduce inequalities in care, so that it was also positive. We had a favorable impact on lifestyle and corpulence. I don't go too much into the results because they are in the report, but these results were deemed sufficiently positive that we decided to scale it up. And also the prescribers and effectors were very satisfied with the organization, and they found that it was responding to the needs of the patients, and therefore they were very keen on the organization being scaled up. And therefore, these positive results, the impact beyond the initial scope of the experimentation, and the recommendation of the evaluator that it should be scaled up, led to the generalization of MRTC in 2022. That's today. And therefore, we have spent the last month of the year to prepare for this generalization. But what is interesting is that what is generalized is not exactly what has been tested thanks to this evaluation process. We have extended the scope of patients, so it's not 3 8-year-old, it's 3 12, but we have also included non-complex obese patients while they were excluded because we realized while implementing the experimentation that they were targeted by the prescribers, but also they have good results, so there is no reason to exclude them. The prescription has been extended to school doctors, but there are many school doctors in France, but for a few there are probably, it's a good way of targeting patients. And we have also reduced the scope of the effectors because we have reduced it to, let's say, multi-professional care homes and primary care centers. And you had some effectors in the experimentation that were associations and they could not fit in the generalization model, so they were excluded for now of the generalization model. The care bundle is a little bit different, but it takes back the main characteristics of the intervention of the experimentation, and therefore, as you see, notice it's a bit outdated because the regulation bill has been published now. The regulatory framework is ready for this experiment to be scaled up. And also we have included it also in the negotiations with the Healthcare Professionals Union so that multi-professional care homes working in wanting to implement this organization can and will be paid for that. I'll finally end up, and we could have had a lot of discussions about all the experiments I talked to you about. These experimentations, most of them are still ongoing, so we haven't the we haven't the evaluation, but some of them are going to be very interesting, and probably some of them will be generalized. But what we can say about this is Article 51 is an innovative and powerful tool to test, implement, and evaluate new models of care and new payment mechanisms of a broad range of situations, which is very interesting because evaluation is key. There are a number of preceding innovation processes in France. All the projects were not evaluated. So what's the point of trying something if you could not evaluate it? The outcome you have is you never generalize it because you never evaluate it. So evaluating all the projects is a huge task. We have 122 simultaneous evaluation. So that's probably the biggest endeavor into healthcare evaluation in terms of health research in France, but it's key. If we don't do that, there's no point experimenting. If we focus on obesity and overweight, notably in children, you see that we cover the scope, and now the idea is not to have new experimentation, but try to understand what type of new organizational model, what type of new regulation we can draw and we can learn from this experiment rather than piling up experimentations. And therefore, probably some of the things that we tested will be scaled up, being mashed up one with the other so that we cover the whole range of what is at stake here. I talked a little bit about that, but scaling up is key. It's a complex and intensive process. It requires at least as much support, probably more than the experimentation, because in experimentation, you have leaders, you have people who early adopters, people who want to change. When you scale it up, you are faced with people that do not necessarily want to change. Therefore, it's probably more complex and you have to full number of people. And of course, however, optimizing these experiments, much remains to be done by healthcare system, and specifically for obesity. So we are very looking forward to have the results of the experimentation to try to design our new healthcare system and probably better address the needs of the population, such as what we've done for the MRTC. So thank you for your attention. And sorry if I was
Thank you for
Thank you so much. I think we're a little bit short in time. So right now, so thank you so much for this intervention. And I know that we have our session with some experts in a quick session. Right now, we have a short break, and then another in about 45 minutes, there is a reception, which is just a welcoming reception. We're just going to have a drink all together for the first day and enjoy the terrace since the weather is nice. And the main reception is going to be tomorrow, as I said, during the introduction. So thank you very much for being here. And I'm sure that during the reception you might have time for some questions, but there is another session right now, and we still have people online. Thank you so much, and see you in 45 minutes. Room B.
Il demande si on veut qu'il ait des piles. Ah, mais il n'y a plus le pied, là?